Hello and welcome to what we call Backyard Boot Camp. Backyard Boot Camp is an extension of our actual boot camp, and we're glad to say that boot camp will happen in person again this year from August the 13th down here at Houston Methodist in the Mighty Training Center. This afternoon I'm joined in the studio with Dr. Ponraj Chinnadurai. He is a research scientist from Siemens, and we both want to come together and thank Medtronic for sponsoring this, an educational offering that's directed particularly at vascular fellows. So this afternoon we're going to talk about something that's near and dear to my heart. One of the reasons it's near and dear to my heart is because of the incredible imaging resources that we have here because of a partnership with Siemens and having people like Ponraj actually embedded in our organization who help us on a day-to-day basis in managing patients and trying to optimize the imaging around them. So what we're going to talk about today really is dynamic imaging for aortic dissection. We're kind of on a mission to try and talk about dynamic imaging for dynamic processes. So over the course of the next hour, we're going to present a case-based discussion, try to convince you of our argument, but there's also an opportunity for you to ask questions. So please send them in. We'll see them. We'll be running banners which actually show you the way in which you can send in questions. So let's take a step back. Okay. I'm not Superman. Ponraj, you're Superman here. And that Superman, really, we're talking about this idea of having X-ray vision and actually being able to see through a patient. Only Superman can actually do that. But, of course, along came X-rays. And X-rays allow us really to actually take X-rays of patients. And I'm certainly old enough to remember that as a resident, first thing we used to do before we made rounds was go down to the X-ray department. We'd give a whole pile of patients' names, and he'd bring out X-ray folders, and we'd put them up in viewing boxes. Probably half the people watching today don't even know what a viewing box is, but you know, it's still mandatory. You actually put viewing boxes in as you actually build healthcare facilities. So we moved basically from films to making these things digital. And that meant that they were portable. You can look at a computer, you can kind of move these things around. And that really was the dawning of a new era. But what I believe, and I'm glad you can see that picture, is the empowering technology in vascular surgery was portable, electronic, live imaging. That's actually a picture of my operating room when I was at Emory. First of all, it had windows, not a great thing when you're trying to do endovascular procedures, but man, I tell you, it was a great view. That table that we had there was actually stolen from the neurosurgeons because it was actually used for X-ray imaging doing spine procedure. You can actually roll the patient completely on the face. And that OEC C-arm at that time was the state of the art because it allowed us to do digital subtraction angiography. And that's really what got vascular surgeons in the game. That's when we became imagers. And I always say the first, second, third rules of endovascular surgery are imaging, imaging, imaging. And yet, we don't teach imaging very well. In fact, there's hardly any lectures actually on imaging. It's all kind of expected to pick it up as you move forward. And this is our old hybrid room. We've now moved into what are called new pheno rooms. But that portable C-arm, I think, was what allowed vascular surgeons to get into the habit of saying when we went to get a job, and I always tell fellows, do not go to take a job where you're not going to be given a full-blown hybrid room. I always laugh because when it came to capital budget time, it used to be they'd come and say, Dr. Lumsden, what do you want for capital budget this year? And I'd say, ooh, I'd like a new Thompson retractor. And they go, oh man, you're an expensive guy. That costs, at least $15,000. And yet the cardiologist and the radiologist would all be saying, I want 2 MRs, 5 CT scanners, for millions and millions of dollars. And so, I think it's part of it is understanding what are the mandatory tools of the trade for vascular surgeons, and a modern day hybrid room certainly gets you in the game.
So if I may add to your the evolution slide that you were showing, Dr. Lumsden.
Yep.
So this has happened a lot in neuro interventions earlier than most other specialties, and in IR, for example. But amongst the surgical specialties, the key differentiating factor is knowing what we did to our patients intraoperatively, or what we do to our patients intraoperatively. And vascular surgery is definitely one of the surgeries in the surgical fields early in the game where you really endorsed intraoperative 2D/3D imaging. But this is where I see, as an imaging scientist being in the field, there is so much opportunities. Now we still live in the realm of opening somebody's chest or abdomen and closing it, and then finding some new findings at the end of the procedure that could have caught if the imaging was available. And nowadays, imaging is much more miniaturized than it was like 20, 30 years ago. So the ultrasound imaging has really evolved a lot. So I really think I sense a lot of opportunity to bring more and more imaging into the operating rooms, so that way these procedures are converted from maximally invasive to minimally invasive therapies, which eventually will address patient care.
Yeah, that's a great comment. And so, for example, we build a hybrid room like the Zigo or the Pheno, and we would say, oh, you want a new angio suite, Dr. Lumsden said. No, I've had an angio suite for 15 to 20 years now. I'm buying a CAT scanner, because that's the new component of this, was this ability to create a cone beam CT scan, to create a CT image, and that then unleashes a whole nother host of things like image fusion, needle guidance systems, all of these kind of things. And I would bet, and I know Siemens think this, that the technology which is present in these rooms are often grossly underutilized. And so that's one of the important themes that we're interested in kind of going forward. But let me step forward, and we think of this as kind of the imaging continuity. And this is particularly interesting to you and I because, again, we're fortunate. Our Heart and Vascular Center kind of owns this imaging, and so we have a very close relationship with the imagers. And a CT scan that's done to diagnose an aneurysm, it's not just used to diagnose an aneurysm anymore. We are taking it, importing it, fusing it, and using that as a really important guidance tool to treat the patient. So it goes from the quality of that image that is acquired preoperative. So for example, we talk about fenestrated grafts, and sometimes we have a scan which is like 2.5, 3 millimeters, in thickness. And I always hear you saying, we shouldn't be doing this. It should be 1.5 millimeter slices, because it makes a big difference in terms of making those fenestrations. And so what that has done is increase how tuned in we are to the quality of the outpatient CT scan. And you may or may not be able to influence that. Fortunately, in our organization, the imaging belongs to the Heart and Vascular Center. So, we don't have absolute power over it by any stretch of the imagination, but at least we can influence it a lot more than just kind of cookie cutter CT scan, which is kind of what happens in the majority of places. So the diagnostic imaging flows all the way through to post-operative follow-up. And I'm not really going to go through this, but we start to think about imaging, not just a hybrid room anymore, but how that preoperative image is acquired, how we use that intraoperatively, and then how we're going to follow those patients post-operatively.
Yeah, this is something that is often not overlooked when it comes to people, even in major hospitals where the hybrid room is being installed. So most of this technology is seen as what happens in the operating room, but there is a lot of decision making that can happen in the positive direction if we optimize these scans before the patient is taken to the OR, or before the patient is taken for the procedure. I think this is where I sense the opportunity. I'm on this personal mission to liberate these images from these PACS monitor. And I really mean this in a way that gone are those days where if I put myself as a patient, if you inject 100 cc's in me to get a CT scan, I want to make sure that is utilized for every step of my care, and not just thrown away right after the radiologist has read through that report, and that report is being circulated through the rest of my care, right? So to me, this is a mission to liberate and optimize imaging, even right from an outpatient setting, so that way that information is carried over through the rest of my care.
Very good. Let me quote another of your statements, and that is, there is nothing you're going to see on an angiogram that is not already present on a pre-op high-quality CT scan, provided you know how to interact with that CT scan. And I think that's one of the lessons I think we're going to learn today from watching you at work is there are DICOM data sets and how you interact and manipulate those to optimize the information that we're interested in. I always say, I don't really care how a CT scan works. I don't really care how an MR works. All I really care about is giving me enough knowledge that I know how to interact with that, I know, and how I can use it intraoperatively to help direct the therapy a little bit better. And the CT scan is fundamentally important for the folks from Medtronic who are watching this. He who owns the CAT scan owns the case. That's true of the surgeon, or the interventionalist, and it's true of the rep. And so the CT scan is very important basically in initial diagnosis, and then much more so we use it, for example, you've got a fenestrated graft, that CAT scan has been used to design the entire graft. And so fundamentally important that it's of high quality, and then we use it basically for image fusion. So we're going to segue really on to start talking really about dissections. And about 30% of patients with dissections have a malperfusion of some kind. You end up basically having to intervene on those. Those are the hardcore indications at the present time for going ahead and intervening on the patients. There are a number of others. But this is a paper I kind of wrote with one of my cardiac surgery partners, Mike Reardon, published in JACC. And it was this concept that once dissected, always dissected. Can we alter the natural history by putting in stent grafts? Now, there are a number of different studies that look at this, a Virtue trial, Instead XL. We still don't really know the answer to that, but we think some of the answers to that are going to lay in, use of modern day type images. And so the case for earlier stent grafting, okay, most people actually survive the initial event. It's not like we're putting these in to save lives, but if the patient basically ruptures, then obviously we're going to do that. Stent grafting does have its complications, and we often think of first do no harm. We worry about paraplegia. We worry about stroke. Interestingly, most of the studies, surprising to me actually, that the stroke rate is fairly high. It's not high, but it's higher than you would anticipate for a patient who's got a non-atherosclerosis-based disease, would be the way I'd think about it. Stent grafting, and credit Mike Dake. I remember Mike Dake when he was at Stanford did one of the first presentations on stent grafting, and it clearly showed that where the stent graft was present, for about 80% of the stent graft, it induced thrombosis in the false lumen, and then that would remodel over time. Where there was no stent graft, it kept flowing. In fact, usually reperfused around the bottom end of the stent graft. So the presence of the stent graft did change the natural history. It didn't alter the entire aorta, but where the stent graft was, it fundamentally changed the way the aorta behaved, and we'll kind of show that. The techniques are improving, but one of the interesting things is when we classify these things, okay, and this is my pet peeve, is there's a number of different classifications, but broadly speaking, one of them was acute, for less than 14 days, chronic was beyond 14 days, and then complicated. But now you think about what that means. Okay, at midnight on the stroke of the 13th day, the biology of your dissection suddenly changes and it becomes chronic. Well, fundamentally, of course, that doesn't make a whole lot of sense. And we believe that imaging may have a role, and because what you're really trying to do is tell the maturation of the septum or the outer wall. That's kind of what you're really looking at. And are there surrogates for talking about acute and chronic?
So one other thing I would like to add here is, especially in a dynamic disease process like aortic dissection, so the best in a non-urgent condition, if it's a type A, yes, we have to intervene urgently, but in a relatively uncomplicated type B dissection, I would make an argument that the best time to imaging is before we put the stent graft in. Before we change any dynamics, we would like to know where the where all the fenestrations are, where is the entry tear, and what like vessels, right renal, left renal, celiac, SMA, what is the involvement. And this is probably the best time to study that, not just in terms of morphology, but also in terms of function, to get a baseline of what was the perfusion to the renals, what are the perfusion to the viscerals. And then whenever we do a treatment, whether you do a dissection stent graft that we now have or a TVAR, we know what is the baseline to compare against. And currently what typically happens is patient gets stent grafts, and then we kind of then we start to work up the patients in terms of physiology.
All right. I don't want to take up too much time here, but here's an example. This is actually an autopsy specimen, so clearly outcome 1, 2, great here. This is actually a young woman who had Marfan syndrome, was transferred here many, many years ago actually, and she was kind of an extremist, but she was only in her 20s. And we opted to put the stent graft in first, see what we could do, and then we opened her abdomen. I mean, basically everything in her abdomen was dead. But we did get an autopsy. We always try to get an autopsy, and interestingly, there were actually 2 tears. We only picked up 1 tear on the CAT scan. Where the stent graft had been placed, it did actually reoppose the true lumen onto the false lumen, so it kind of works the way you would think it was. But downstream, of course, the dissection persists, and what you're looking at here is, and this is kind of pathology in action, you know, if I can show you this. This is a tube of atheroma, because this aorta has almost been completely evulsed circumferentially, or at least the intima has, and this is a tube of atheroma bridging into the left renal. The way that pathologists open these is from behind. And on the right side, you see it's been completely evulsed. So here's this little nipple of intima. Here's the renal artery, and this is kind of what you have to deal with sometimes, and getting a wire across that. It's usually not as difficult as you think, but I think if it's completely evulsed, it's probably hard. If the intima is stretched out, then it's probably pretty easy to actually do this. And so, you know, this obviously can be a devastating disease. Now, the idea of putting stent grafts in is to induce thrombosis in the false lumen. So here's the situation, is that we had to put a wire up and it ended up in the false lumen. So, there's an opportunity for observation. And so we put an IVUS catheter in it and we let it sit there, and then we kind of rerouted the wire into the true lumen, and then we deployed the stent graft. And so we're going to show you, really, here's the IVUS catheter. Here's the device about to be deployed. And I want to walk you through this, what happens. This is an example of dynamic imaging. Here's the stent graft. Here's the septum. Now what you're going to see really is that all of a sudden it deploys. This is what you want to see. All of a sudden the flow in the false lumen slows down. We presume that that's the antecedent for thrombosis actually occurring. And so there's all of these different dynamics which are kind of, you know, in this diagram in the middle that we're expecting to actually see. And this was probably one of the first times that I'd actually ever seen anything like this happen. So from 0 to 100% men, sometimes these patients we opt to do nothing. We just medical management. Sometimes we have to cover it. I'm not going to go into all of that. We tend to use dynamic imaging. This is an example of a dynamic MR. We may touch on it as the candy cane view. These little black and white things that are going backwards and forwards represent to and fro flow occurring through the evulsed intercostals. So people say, where are the fenestrations? There's dozens of fenestrations. And so the idea there's 1 or 2 fenestrations is ludicrous. And again, what this showed you was how dynamic that flap actually is. And we believe that as these remodel, they become less and less dynamic, but that's not really all that consistent. And here's an example of a dynamic obstruction in action. The people who actually made this classification are brilliant. You know, dynamic versus static obstruction was done without any imaging. It was conceptual. Now we can actually see this Pinchcock effect basically on the renal artery, and one of the reasons that we think that this is important. No cardiologist would think about, or cardiac surgeon would think about treating a mitral valve with a single CT scan. It's all about the dynamic imaging that's going on. And we believe that we're trying to develop this concept in static imaging. We say one view, and angiography is no view. We believe basically that one instant in time in a CT scan or MR is essentially functionally no view. And there's so much more information basically that you can get out of that. And so this is going to be used as our segue. This is a type A dissection. Ponraj is going to go through this in particular, but it's just to show you how dynamic these structures actually are. So, Dr. Chinnadurai, I'm going to hand this off to you.
Thank you, Dr.
Work your magic.
There is no magic. It's about how we interpret the information that is right in front of us. So so to kind of take it as a segue, so you showed 3 dynamic imaging modalities in the last couple of slides. You showed the IVUS, you showed the CT, dynamic CT of the type A dissection, and the dynamic compressions diagnosed by MRI. So of all the 3, IVUS, obviously you need an intra-aortic lexus that is more of an intraoperative use. So we are going to talk extensively today about dynamic CT and MR imaging, specifically in the context of aortic dissection. Why aortic dissection? This is a classic example of a dynamic disease. So we talked about a type A dissection, and this is an intraoperative picture which I had the courtesy of meeting and having conversation with Dr. Bavaria in one of the training courses, is to see what the surgeon sees. And this is kind of what we are in reality trying to non-invasively image with MRI or CT images. So what you see here is just flow in the false lumen in a really dilated aorta where you're looking through the false lumen, and how transparent and weak the aortic wall that we are seeing here is. So this is essentially the root cause when we wanted to be able to identify, hopefully and preferably before such dissections happen in a non-invasive setting. So, and there have been plenty of classification systems, like starting from our own DeBakey's classification in Stanford, and now there is a recent classification. The reason I'm talking about this is one of the most important things is to know the location of the entry tears and also all the fenestrations. That is so important to determine what type of treatment that the patient is getting. And in addition, having the right sizing will also help with identifying the right device. So I'm going to start with these images. Like the one on the left is a CT image with EKG gating, where we are seeing a entire aorta dissected, and you're seeing the dark lumen is the false lumen, and the brighter contrast-filled lumen that is incontinuous with the aortic root here, and the left ventricle is the true lumen. And on the right here, you see a cine image in a 2D slice, where you see across different cardiac phase and maybe some respiratory movement of what's happening to this dissected aorta. So we're going to go through some clarification of terminology, and I've learned this a lot by working with multiple specialties, surgery, cardiology. It's really important to make sure what people understand what I say. So we are going to talk a lot of concepts, but I would like to urge to see them in two different contexts. One is especially in a setting of aortic dissection, there is always going to be a lot of cardiac movement. So we are going to resolve our imaging by EKG phasing. So that's one way to look at it, EKG gating. The other aspect to look at is there is going to be a lot of differential flow in the true lumen and the false lumen. So we have to get our contrast bolus timing right. So we are going to look at these imaging in the contrast bolus timing, what we call as time resolved angiography. And sometimes we can also combine the both, especially if you're talking about dissections in the ascending aorta, where there is a lot of cardiac movement, and also there is a chance of differential flow in the true and the false lumen affected by the timing. So we're going to go in a series of increasing complexity. So the regular cookie cutter imaging approach that we do is you go to Epic, order a CT chest, abdomen, pelvis, and this is what you get. Non-gated, contrast timed for a particular phase, and then we move into EKG gated, and then I talk about time resolved contrast angiography, and then combining number 2 and number 3 and how we can make use of that in dissection. So this is what your CT tech does. You don't often get into acquiring these images, whereas here in the operating room we control the dynamic, or what I call as dynamic is digital subtraction angiography in 2D, where you control the contrast injection and you trigger the acquisition. Whereas if you have a CT technologist, they have two options. If you ask for a CT of a PE protocol or pulmonary embolism protocol, they put a region of interest in the pulmonary artery, and then you get your scan in the pulmonary arterial enhancement phase, which as you can see is so much earlier to the aortic enhancement, which is the curve number 1 and 3 are these ascending and the descending aorta. So you can, just to kind of relate, I know I'm going in a very non-fair analogy, but to put it in context to people who do DSA imaging on a daily basis. Imagine you get into the OR, you do your DSA, you inject your contrast, whatever, 20 cc's or 50 cc's, and you're just taking one frame, whether it is in the pulmonary or the arterial. And that is kind of what we do with conventional CT imaging. And the reason why I'm kind of trying to push us away from that or progress from that is, if I ask you this image, show you this image, Dr. Lumsden, and ask, is this 2 lumen dissection or 3 lumen, or do you see there is a entry tear here?
Not really. I mean, I see almost like an oval septum in the middle, and there's a low density area at 12 o'clock, and I'm not sure what any of that is.
Yeah. So, and this is kind of what we typically base our diagnosis. And the reason I intentionally picked this slice is, if you look at your LV contour, there is a lot of haziness here, you see. So this is what we call as the septum is moving with cardiac motion, and sometimes patients moving or respiratory motion. So there is a lot of motion artifact here. I'm just going to skip a couple of slides and show the same image, same slice of an EKG-gated slice, and I'll come back and explain how this is done. So this picture, I want you to, so it's the same slice that I showed you on the right, and now you have the EKG-gated image, and you see the LV contour. And at least based on this one particular slice, even though in this image on the right, it looked like there is a possible 3 lumen or a dissection entry tear, here you know clearly that this is true lumen and this is false lumen. So, and this is the case I'm making of how we can get from conventional CT to, especially in a patient with dynamic disease process, it's probably okay for aneurysmal disease, especially if the aneurysm is in the descending thoracic aorta or the infrarenal aorta. There is not a lot of cardiac movement. Not a lot, I say. There is a little bit, especially when we are thinking about evaluating endoleaks and stuff. But this is the reason why we wanted to go to the next step. The reason why I'm saying it now is now we have latest generation CT scanners that have lower dose and higher speed. And this picture is just showing what is happening inside the CT donut and how fast the X-ray tube and the detector is spinning. And I can pause and show that there are 2 X-ray tubes here and 2 detector rows here. So this is a dual source scanner, and I would love to point the viewers to this video in our DeBakey channel, our YouTube channel by Dr. Faisal Nabi. As you can see, it has quite a number of views. This goes through the entire detail of how we can optimize and how the basics of cardiac CT and a lot of technicalities behind it. I'm not going to go into the details of it. I'm just pointing that as a resource, but we are going to discuss, at least within the context of dissection, how we are making use of this gated CT imaging.
Yeah, you've mentioned that YouTube channel. Just to say that this presentation will be posted on that YouTube channel. Typically it goes up tonight, then gets edited a little bit for tomorrow. We're very proud of the fact that yesterday we hit 50,000 subscribers. So we're doing something right. I mean, by and large, there's some pretty high quality lectures and cases for any of you who are interested. So for those who have may missed out on this or who want to get follow-up, it'll be posted on that DeBakey CV YouTube channel tonight or tomorrow morning.
That's a great resource. I learn a lot by watching some of these videos as well, and especially in terms of what goes in the OR. Sometimes in a meeting the surgeon doesn't really reveal, but when you are in the flow explaining a case, you get to pick up a lot of these little things. And there's one more disclaimer I would like to make before we go to the imaging is most of the things, almost all of the things except for the last slide that I'm showing today, is all possible in a commercially available 3rd generation CT scanner across vendors. And to me, this is something that I want people to think that this is not although I'm a research scientist managing research projects locally, what I'm talking today is mostly involves custom configuration to what we wanted to image, mainly targeted towards dissections or endoleaks, for example, and it is quite easily possible if you have the latest generation CT scanners.
Yeah, that's incredibly important. We've been kind of showing pictures of dynamic MR for years, and all we get here is, well, not everybody can do this. You need the people who are vested in creating these sequences and dedicated techs to be able to do it. And so that's true. I mean, it's a lot more labor intensive to get images out of it. But why we're excited about dynamic CT, we're excited about them both, to be completely honest with you, but we realize that dynamic CT is something that can be generalized a lot more easily than can dynamic MR. And again, you touched on something. So if we're just going to diagnose an aneurysm, we're not really advocating doing dynamic CT.
Yep.
It's where there's a dynamic process that's important. Dissection is certainly one of them, and the other thing that we've been using it for is troubleshooting endoleaks, knowing where the endoleak is coming from, because it's just like doing an angiogram, and if it's a type 2 endoleak, tracking which are the inflow vessels, which are the outflow vessels, and obviously you'd like to get both of them, but if you're going to only get one of them, you sure want to optimize the target being on the inflow vessels.
Okay, so let's get going here. So I'd like to explain here by showing the image first and then come back to the technique. So what happens when we say retrospective EKG gating is the term retrospective is during this CT acquisition, you see this yellow bar that shows the spiral acquisition, and the data is acquired across 2 or 3 cardiac cycles or cardiac phases.
So it's continuous.
And continuous. And the X-ray is always on, at least during this retrospective gating for these like 2 or 3 heartbeats. And once you are acquired the data, you at the scanner console itself can split the data into 10 or even 20 different phases across the cardiac cycle. For example, if you are staying closer to the QRS complex or just after the QRS complex, then you get like more on a systolic phase. As you can see, the origin of the right coronary artery has a lot of movement, and the best phase in cardiac imaging is diastole, where there is not a lot of movement, and there, so once you acquire the data, it's almost like going back and reviewing your DSA and like picking your frame where there is not a lot of movement and figuring out your entry tear or your compression or the extent of dissection into the SMA or celiac. So, and to me, this is what is easily done in CT with retrospective gating. And this is an example of a retrospective gated CTA. So what I would like to point out is, if you look at the contrast intensity in the aorta, it's almost the same. And this is the way you differentiate this from a time resolved imaging. So this is just gated, one contrast time point, EKG-gated cardiac imaging, where we are showing the type A dissection and its extent into the descending thoracic aorta. And
so
we talked.
Can you go back to that for 1 minute?
Mm-hmm.
So, obviously, one of the reasons this is important, I usually show the slide and say, if you were in person, I'd pick on one of the fellows and say, why don't you size this for an endograph and tell me how we're actually going to pick a diameter for this. Generally speaking, remember, we're doing this off the one snapshot in time,
yep.
a snapshot that you have no control over when it actually happens, mm-hmm. and yet this is what could be going on for the rest of the cycle.
Yes, and one other disclaimer I would like to make is, for these EKG-gated imaging, you're injecting almost the same amount of contrast. So I don't want the viewers to think that, oh, this needs extra dose of contrast. So it's almost like you're already given the contrast, you've decided not to do EKG-gated imaging, even though some of these scanners where we get these conventional CTA are capable of doing this EKG gating. So if there is one thing that I would like to drive home today is, especially in the setting of dissections, we will gain a lot about the septum by doing EKG gating, gated imaging. And there are other ways of reducing radiation and improving temporal resolution. So this is another way. You see, it's not a continuous yellow line here for radiation. Here, you track the EKG signal of the patient, and then you decide, you tell the protocol, I want diastolic phase in this particular patient. So then you get only diastolic imaging. The X-ray is on only during diastole, and those data acquired across multiple cardiac cycles are stitched together and shown to you as a systolic or diastolic phase imaging. So we do this for, if you need long coverage, say go from neck vessels all the way to the iliacs, we often do a quick flash prospective EKG-gated protocols. And the same concept applies in MR as well. So these are dynamic images with EKG gating, where you're seeing the relationship of the septum to the visceral vessels like celiac and SMA and the renals in this particular case. And we'll go through this in timing. I'm touching the technique first before we go to the
Sure.
cases. So the third the concept I wanted to progress down to is this time resolve. So just the same curve that we saw for PA and the aorta, for example, if it's a aortic dissection, we wanted to make sure we don't miss this timing bolus. So often you get CTAs evaluated for aorta where the contrast is bright in the pulmonary artery and there is not a lot of contrast in the aortic lumen.
Again, so if we were in person, we'd say hands up those who send a patient for a CAT scan and they come back and the bolus has been missed and the study is essentially worthless. Mm-hmm. And I'm sure all the hands are going to go up at that point, because it's not an uncommon problem.
Yes, it is.
But it is complex in dissections because there are multiple different flow patterns that you're dealing with.
So for example, imagine the technologist doesn't know. To be fair to the technologists, they don't know if the aorta is dissected. So imagine they put a region of interest, place a region of interest in number 2. And if that aorta is dissected and we are looking at false lumen, we are going to wait for contrast to arrive, and the contrast would be paused, and then they would start the acquisition. So I think this is where the way we overcome that is to do a timing bolus and get a slice where we get both ascending and descending aorta, and then check if there is dissection or not. And based on that timing bolus, which you can get very easily with 20, 15 cc's of contrast, and use that timing for our actual CT imaging. So there are techniques we can automate to do this, but there are certain ways we can.
And so the curves on the right are die-arrival times
Yes.
in different locations.
Yes, the y-axis here is the Hansfield unit, is just how dense the pixel is, and the x-axis is the time. And this gives us a time attenuation curve, and based on this, we can decide. So for example, instead of taking one shot, and our probability of getting it right is definitely a little trickier, instead of that, you can configure protocols with, hey, I know based on the timing bolus, the aorta gets opacified at 10 seconds from the IV injection. You can get multiple volumes around that 10 seconds, so you get the flow in the true lumen and the flow in the false lumen as well.
So I think your analogy with doing DSA is a really good one.
Yep.
You inject the dye, you wait 20 seconds, you turn on the X-ray and you can't see anything.
Yep.
Doesn't mean the dye wasn't there, you just haven't acquired at the right time.
timing.
The same thing happens. So for example, one of the things we found to be useful was die-arrival times in the aortic aneurysm sac. If it arrives at the same time as dye inside the aortic stent graft, it's probably a type 1 endoleak. If there's a big delay between the dye arrival times and the contrast flushing down the aorta, it's probably coming through a circuitous route, and so it's a type 2 endoleak.
Yes.
So these dye arrival times are something that we don't really think about in vascular surgery, but all that information is available.
Yeah, especially in a dynamic disease process like dissection and endoleaks, these time attenuation curves can help really with improving the accuracy of our diagnosis. And I also noticed one of the questions here is, okay, now we are getting, instead of doing one scan, now we are getting like 6 scans. How much radiation?
You're irradiating the heck out of the patient, Ponraj.
So, and this is where I go back to the latest generation CT scanners, where we really can customize. It's not like a cookie cutter approach where if you get a CTA, chest, abdomen, pelvis, not every scan had to be done at 120 kV or 100 kV. So what we try to do is, okay, prioritize what information you need, especially in a case like aortic dissection, where the priority for having a temporal information is more. So we tend to compromise on the image quality. You don't need a pretty picture for a fancy competition, where we just need just enough resolution to resolve the entry tears, but at the same time have the dynamic images. So what we do here is...
So can we, generally speaking, the dynamic CT scans that we're doing do not have an increased amount of radiation exposure.
So I would say they are equivalent to a typical aortic arterial and delayed phase imaging that you are getting. So, and that is typically done at 100, 120, because when you are doing these routine protocols, we often tend to go higher on the kV side to make sure all different patient habitus, the image quality doesn't suffer. Whereas here we try to lower our kV, and at least in our experience, we could acquire a dynamic scan, whether it is for endoleak or aortic dissection, at almost equivalent dose as a triphasic or a non-contrast arterial and delayed imaging, which is
so let me deal with the other question. The question is Doppler TE during surgical endovascular procedures used as a reference to improve flow assessment by CT or MRI? I think we're driving at, can we use it to validate, your images? You show these pretty pictures, and we certainly can compute a bunch of stuff. And I'll go back to Peter Taylor in London, said, this is just a bunch of pretty pictures. How do we know it bears any semblance of reality? Actually, it's highly quantitative, it can be checked, and it's very accurate. Now, what I would say is that, do we use TEE? Do we use TEE with color flow? Yes, we use TEE in essentially all dissections. It doesn't really show you the entry point though, because that's in the kind of blind zone for TEE. We mainly use it just to check off where the wire is. It's obviously used basically in type A dissections fairly significantly, and when they're coming off pump, but we're not really using it to validate what we see in these dynamic studies.
Yeah, so there's one more thing I would like to add to that, Dr. Lumsden, is now we are getting in from qualitative imaging to quantitative imaging. So especially with CT, with these time attenuation curves, or even when you go to MR, we have these time resolved sequences. You can get the same information there, and now with the latest 4D flow sequences, we can really measure the physiology. So I think this is where we are kind of changing the realm, especially in the aortic dissection, is not just morphological, but also getting towards functional / physiological imaging.
Right. We're moving on in time. We may have to do another one of these so we actually cover some of the cases that we were talking about. So
okay,
let's
go
see.
Ahead. Let me see if I can wrap this up quickly. And so this is typically what the patient goes through. So especially in the latest generation scanners, the table movement is also accounted for to increase the long axis coverage. So I'll skip through this in the interest of time. So what you're seeing here is the similar time-resolved angiography. The image on the left is from one of our dissection cases with CT. The image on the right is the same patient happened to have an MR, time-resolved MR angiography, and you can get this similar information with, you can even see the flow from the SMA into SME into the portal system so well. And it's the same patient underwent TVAR and an EVAR to seal or close the entry tear in the infrarenal aorta. And once you have the device in there, especially if you start to put devices that are non-nitinol based devices, then our post imaging with MR kind of gets affected a little bit. So we in this particular patient, we got a post imaging CT, dynamic CT after this. And the reason I'm saying that is it's really up to the clinical question. We decide which modality we should use.
Yeah, I think that's, I talk about it as strategic imaging. Okay, I mean, the problem is you get cookie cutter imaging in the majority of places. Okay, you got a dissection. We really like to know where the entry points are. You say chest, abdomen, pelvis, you get pre, post, and some kind of delayed.
Yep.
Lord goodness knows how they actually choose that in a dissection. Where, you know, we don't really care about what's going elsewhere. I mean, it's a matter of investing the time and the effort and energy and answering the clinical question that you as the interventionalist need to be able to address. And so if you're looking at a type 2 endoleak, for example, you know, all you really need to do is to see the aorta and enough of the feeding vessels that you can see what those flow patterns are. So we don't really care what's going on in the spleen. We don't really care what's going on in the liver. And so that's what we mean by strategic imaging. It's tailoring the menu or the recipe for doing the CAT scan to answer the question. And that means you've got to be engaged in it and have a certain amount of influence to be able to do that.
So there are two ways we can make this strategic imaging better or happen. Like one, you can approach this from a technology standpoint. We can make our protocols like easier to use or safe proof, where you, for example, when you're ordering a CT, you could answer a bunch of questions and then that can be converted into a protocol and goes into the scanner. The other approach is the field has to also evolve, where currently I see a lot of gap between when a surgeon or an interventionalist ordering an imaging study until they get the images. There's got to be a lot of missing chains that had to be at the same level of information. Otherwise, one mistake, the patient needs either a repeat imaging or has a suboptimal imaging, which has to be somehow offset or complemented by intraoperative imaging or additional contrast in the OR. So I'm going to quickly jump to our case reviews section. So this is one of our recent cases. Dr. Lumsden, 68-year-old female, you probably know, have the history. Maybe can you walk us through?
Yeah, before you do it, can you, what did you switch into? What are we now looking at?
Okay, so I switched from PowerPoint to one of our image viewing platform called Singovia. And this is kind of where all the CT, MR, ultrasound, even angio processing can be done. And the reason I see this, I have shown this is this can do much more than a conventional PACS system. So most often when you order a CT, say at the middle of the night, you go to the PACS system to look at the images. And what this application enables us to do is do a lot of post-processing, and there is a lot of automation behind every one of these applications that we are seeing here. And it is definitely leaps ahead of the DICOM viewers we have incorporated in the PACS, conventional PACS platforms.
Okay.
So,
and are these two different CAT scans we're looking at?
Yeah, so what I did is took, starting from the patient's CT images,
So the value of this is to be able to, I mean, so we all go to clinic and we all spend a lot of time, and typically we pull up one CAT scan, we go, well, has it changed? So go get rid of that, pull up another CAT scan, scroll through all of this. What you're saying is that using this system we can pull up 2 or 3 at different time points, line them up side by side and scroll through them, and it'll be roughly the same level. That
so what it does is, so right now what you're looking at is, if you're looking at the, I don't expect you to read the font, but the image on the top left is the most recent one before we did the intervention. All the other 3 images are from the conventional CT images. And the image on the top left is the gated CTA that I was showing. So let me run this through from the top to bottom. And these are all automatically aligned based on the automatic detection of landmarks.
So how does that work? Well, what are the landmarks?
So the landmarks are, so there are thousands and even more of CT data sets where the algorithm knows how to find the iliac crest, aortic arch. So like it's trained to identify these shapes, shoulders, scapula, ribs. So once it finds that, it estimates where things are. It identifies the kidney based on the shape, for example, and then it aligns it based on that contour. And it is not 100% accurate, but at least if you're, it is better than our current workflow of scrolling through manually in each time points. And here, let me just scroll from the top, bottom, and then we'll assess this case. So here, the image on the top left is the gated, and the other 3 are non-gated studies. So we see the true lumen and the false lumen here. And the image on the bottom right is before the dissection. So that's often I prefer to load that as well, to kind of see if I can pick any harboring any little markers that I can see why the patient's aorta dissected. So now I'm scrolling down towards the feet, and I think we went through it. So this is the artifact that we saw, and so this is where I see a fenestration here. So here we see the celiac, SMA, and then the right and the left renal. So this is just one time point. I'm just showing this to you. And so then the patient underwent MR imaging. So this is ferroheme MR with time-resolved angiography. So
ferroheme is
an ion-based contrast agent. So instead of giving gadolinium to patients, so we can give ferroheme. It is excreted by reticuloendothelial system, so you're not really getting a hit in the renal function, but you still get your time-resolved information. So
it's still under research protocol?
So the protocol itself is commercially available, but the ferroheme is not really indicated for this contrast agent.
We use it a lot. Any patient elevated creatinine that we want an MR, and they get a ferroheme MR. I've not seen it widely used elsewhere. I mean, we seem to do it, probably 20-30% of the MRs that we get.
Most often it's the routine use is like gadolinium, and not many people have adopted to ferroheme, and I don't think it is available even commercially in Europe, for example. So here these are like so the reason I'm switching to MR is here you don't have even that extra radiation. We have the ability to acquire multiple time points then. So here you can see where the IV axis was and how the contrast is arriving in the SVC. And as I scroll through the time point, here you can see the contrast evolving in the true and the false lumen. And
the whole body angiogram.
Yeah, exactly. And here you can, like, as I'm scrolling through the time points, so now we see the contrast in the RV, PA, and you can see the PA bifurcation here. And now as I go through the next time points, so here you see the contrast filling in the aorta. So I'm trying to get to a candy cane view of the aorta. And so this is another way to really understand, like here we see the dissection flap, and you can see, at least based on this image, I can see the true lumen filling all the way down here, and if you look at the false lumen here, it's filling at least visually bottom up, right? So inferior to superior. So that is a useful information to decide on what kind of treatment we are going to do to whether we're going to intervene at all or not.
Okay, it's a pity we're not doing this in person, because we'd be able to ask the question about, okay, it's filling from inferiorly to superiorly. And yet, this is a type B dissection, isn't it?
Yeah.
But there's no entry point just beyond the left subclavian, or was there? And we just didn't miss it, or is it thrombosed?
Well,
I mean, I don't know that anybody knows the answer to that, but you know, at least we're starting to dissect out. Oh, now we go to dissect out the dissections. Sounds like the title of another paper. Does it make any sense to put a stent graft in proximally? And this is a discussion that happened in our complex aortic conference. So actually, this is kind of a little controversial case. But the reality is, without this, you wouldn't even have known that.
Yeah. Maybe you would have known that when the patient is in the OR with IVUS imaging, you will be able to figure out if there is no entry tear, and the first entry tear is more in the infrarenal aorta at the level of the visceral vessels. So this patient also got so I'm just going through the same CT images in multiplanar view. So what I've shown here is just an axial to compare it with previous imaging modalities. So here now you can interrogate the aorta in a multiplanar view and like really look for if there are any entry tears in the proximal descending aorta. And again, this is just one time point that we are looking at in the arterial phase, but at least I don't see any filling of the false lumen, at least until the distal entry tear, which is at the level of the visceral vessels, like right there, right where the celiac and SMA is. So this is, we're not going to, I don't have enough data, but we are in this process of going through this and trying to see how we can use CT and MR. I don't see them as one replacing the other. They are complementary, where with a better spatial resolution with CT, we'll be able to map out the entry tears and the dissection flap better with CT. And especially with MRI, we'll be able to get much better assessment of the time resolved component and also the flow information. So if I go back to the PowerPoint slide for a second, so we have shown the value in type B dissections, and it also can be used to guide treatment.
There's an MR.
So this is so in this particular case it was a CT, but it doesn't matter as long as it's a 3D DICOM data set. We'll be able to incorporate that into your fluoroscopy to guide your treatment, especially if the patient has borderline renal insufficiency.
Yeah, I think that's important, because I don't know if I've ever seen this anywhere else. Actually, we not infrequently treat patients with image fusion using an MR fused onto the patient.
Especially if you do ferroheme, there is not a lot of hit you are giving on the kidneys, and you can do most of the procedures. Occasionally you might want to do a little bit of angiogram towards the end for a completion angiogram, but most of the times, for most of your pre-interventional steps, you can replace that with image guidance. I'm not going into that, we can talk about that later, but I would like to finish with the type A case and to give a food for thought before we wrap up. So this is one of a very interesting case. So it's a 78-year-old patient treated by one of our vascular surgeons. Patient had like end-stage pancreatic cancer and had an ascending aortic aneurysm like this. So we did all the image fusion and deployed the cuff. So this is the baseline. What you're seeing is the ascending aortic aneurysm. And so this is a gated CTA which was done, and still the aneurysm was filling. So the image on the right is when we did the gated dynamic CT imaging. So what you're seeing here is an evolution of all the technologies. Conventional CTA, you can see the mitral valve leaflets are not really well resolved because there is no gating involved here. This is gated imaging, but no time resolved. So this is time resolved imaging where you could see the endo leak, and I'll show further images. So conventional CT, gated CTA, and time resolved images, and I hope this movie will answer or convince people. So now you're seeing the contrast arrive in the SVC, PA, left atrium, and into the ascending aorta. And what we were able to clearly demonstrate is a type 1A endo leak coming from the proximal end of the stent graft. And
I'm sure they said, "Oh, great! I'm glad you've demonstrated that. Now what?"
Well, the way I see this is we have a set of tools, and depending on where and what clinical question, if it is type B dissection, where you're not really concerned about EKG gating, we could do a just dynamic imaging, where if you're moving towards arch interventions and ascending aorta, you could do both dynamic plus EKG gating. So this is, I'm just showing you that kind of toolkits, that tools that we have in our toolkit that could be applied to answer that question. What I would really consider suboptimal is, even after injecting 80 or 100 cc's of contrast, we still don't have the diagnosis, and the patient either ruptures or goes to the operating room for a diagnostic procedure. So that to me is what we are trying to change here.
So the simple way of thinking about this is that CT has got better spatial resolution.
Yep.
MR gives you better physiologic resolution.
Or temporal resolution.
Temporal resolution.
And functional imaging
Is
capabilities.
there a role for combining these?
Yes, definitely, but the price we pay for is 2 scans. Especially with dynamic CT, you saw the actual acquisition. It hardly takes less than a minute. The MR takes, especially the MR images that you saw, takes on an average 1 hour image acquisition. So scan time. So if we kind of like come up with the right mixture, where if you do a CT and then get the right MR sequence that complements the information from the CT, then we can bring the scan time from 1 hour to maybe 15-20 minutes that is bearable by most patients. And this is where the researchers have to come together. Currently, even if you look up aortic imaging research teams, there is an MR research team and there is a CT research team. And this is where I think eventually when the imaging, I mean, even now the availability of these scanners to our patients is already there. It's the skill set and the configuring the right protocols is what is missing. So I really encourage the community to really see, instead of looking at individual modalities, and even companies to not look at individual modalities, to put it all together and see how we can address this for aortic dissection, how we can address this for endoleak. To me, that is, maybe I'm being too idealistic here, maybe that is where I think we can address the question that is posed by the person who is ordering the scan.
Well, you are idealistic, but that's good. That's kind of what drives us towards doing things better and better. I mean, I guess the message we want to leave you with is that dynamic imaging for a dynamic process, static imaging for a static process, that we've kind of moved from saying MR to dynamic CT is something that could be implemented in your organization. We're glad to help in any way if that's something you need information for. What I guess we're closing with here is this picture, if you can put that up, of 4D flow. Right? 4D flow is real flow. It's not computed flow. This is a measurement of actually flow. And where we're moving to is thinking about getting a dynamic CT. It gives us the resolution, the spatial resolution that we need, and potentially overlaying on top of that a picture like this, the 4D flow. Because I really believe that the solution to understanding how long a stent graft we got to put in is it exists in understanding these flow patterns. And then we got to make a decision about what we can do, what is optimal in those individual patients.
Especially in the setting of type B dissection, the best time to do this imaging is before we put the stent graft in. And that doesn't mean you cannot do it after the stent grafts are placed. But again, I would like to clarify, these are not images that are computed. These are not CFD images. These are actually measured phase contrast images across 3 axes, and you kind of visualize that data as these flow lines here, with red being high velocity jets and blue being low velocity jets.
And that's a retrograde flow pattern in the false lumen.
In the false lumen, exactly.
All right, well, once again, you and I talked too much and we only got through a fraction of what we wanted to do. We may have to do that again. You want to round out with the summary here? And let me, before you do that, thank Medtronic again for supporting this, and thank all the residents and fellows who watch this. And thank you, Ponraj, for very eloquently again explaining these complex concepts.
Thank you very much, Dr. Lumsden, for the opportunity. I learn every single day by being in the field, and I'm more than happy to share what I learned, more purely from an interventional standpoint. And one thing I would like to leave with is there still exists a gap between how imaging is done for a diagnostic purpose versus interventional purpose. So I really think, especially if there is an intervention planned in mind, there is a lot of room to influence your diagnostic imaging, so we are not reinventing the same information that's already there in a CT scan in the operating room. And I think that is probably where the future of imaging, especially for the aortic dissection, should evolve to, in my opinion.
Well, on that note, have a good night, and thank you all very much indeed for tuning in.
Thank you.